Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and we'd like to thank our episode sponsor, Bristol Myers Squibb, for their support of Myeloma Crowd Radio and for this particular program. I think all eyes and ears are on the coronavirus, and many myeloma patients are being impacted by it for all aspects of their care. Dr. Joshua Richter is at Mount Sinai, New York City, one of the epicenters of the U.S. outbreak to date, and he's very aware of how it's impacting his myeloma patients and those around the country. So, Dr. Richter, welcome to the program.
Thank you so much for having me.
So before we get started, let me just give a short introduction for you. We have a lot to talk about. Dr. Joshua Richter is Assistant Professor of Medicine at the Tisch Cancer Institute at Mount Sinai at the Icahn School of Medicine in the Multiple Myeloma Division. Dr. Richter previously practiced at the John Theurer Cancer Center at Hackensack University and at Rutgers. Over the course of his career, Dr. Richter has led significant research on the development of new or novel multiple myeloma treatments, including carfilzomib, selinexor, panobinostat, daratumumab, pomalidomide, isatuximab, and ixazomib. His research also includes immunotherapies, stem cell transplant, and optimal treatment strategies in multiple myeloma. So I think we'll just jump right into the show today because it's such an important topic and relevant topic. But what are you seeing, or how are myeloma patients being impacted by this coronavirus? And what considerations are you taking in account for just about everything, I think?
So obviously this is the most important question that we're all dealing with. And, one of the things that I have to say is, despite the concern that everyone has, the medical community and the myeloma community is banding together in ways that have never been done before to make sure that everyone gets the optimal care during these crazy times. So, there's some broad things that we're doing, and then much of what we're doing is patient by patient. So from a broad standpoint, we're trying to limit quote-unquote non-essential things. And, that's complicated for a myeloma patient, what's essential and what's not. Transplants, for one, are not always essential. So for a number of patients with newly diagnosed myeloma, we give induction therapy, and then the plan is to go on to transplant. Many people achieve a good remission with the induction, and if we're able to hold off on transplant right now, we are. And the big reason is that transplant requires not only a several-week stay in the hospital, which may be more risky at this time, but it also suppresses the immune system. And we want to make sure that everyone's immune system is as intact as it possibly can be during this time. We also very much encourage social distancing as much as can be done. And thankfully, in many places, the ability to order food and or drugs and other supplies is available. In terms of day-to-day therapy, we're trying to switch over as much as possible to oral therapies. So there are a number of oral therapies that patients are very familiar with, drugs like Revlimid and pomalidomide. There are some oral therapies that people may be less familiar with, drugs like ixazomib, selinexor, and panobinostat. And what we're doing for many people is trying to utilize regimens that use oral drugs. This way people don't have to come in on a weekly or twice-weekly basis to their offices and hospitals to get infusions. So ixazomib is a proteasome inhibitor, much like Velcade or carfilzomib. And for many intents and purposes, it's very similar to an oral version of Velcade. So many people that are receiving Velcade, we're switching over to ixazomib or Nenlaro. Panobinostat is another drug it's not as commonly used, but an extremely efficacious drug and can actually resensitize to previous drugs. Meaning if someone's on Revlimid and Revlimid stops working, you can add panobinostat and resensitize them. So where in some cases we might have added Velcade previously or daratumumab or carfilzomib, now we can add drugs like panobinostat to control the disease without needing multiple visits. And selinexor is another amazing oral drug that was recently approved, but we know that we can combine it with other oral drugs, including drugs like pomalidomide. So we're really trying to switch things over to oral as much as possible and limit the number of blood tests as needed because you still need to go out to either a lab draw center or your hospital to get blood draws. So really spacing things out and having regular communications with patients, including things like telemedicine. So a lot of places are embracing telemedicine to have video chats through our phones and our devices to talk to patients, to go over their symptoms, review plans of care, to help manage as much as possible so that people don't have to unnecessarily expose themselves to anything outside.
Okay, that's a lot for myeloma patients to take in. So let's just break it down, if you don't mind,
Sure.
to some
Of course.
specific things. So you mentioned testing and blood draws. So if I'm going in, let's say monthly, and I guess it depends on how your myeloma is behaving. Like if you're in a remission status and you're getting tested every 3 months, so what you're saying is you could just push that out and maybe wait an extra month to get testing if your myeloma looks like it's behaving appropriately.
Absolutely. I mean, this is a case by case, and patients should definitely talk to their care teams, but your sentiment is 100% correct. For patients who, we do a lot of things out of routine for optimal strategy, but if we're checking things every 1 month, for many patients we can switch it to 2 or 3 or even beyond. So I completely agree with you.
And then for patients who have maybe increasing myeloma, what are you recommending for them in terms of testing or blood draws?
So, that's a more complicated issue. So, there's 2 types of progressions that we generally talk about in myeloma, biochemical and more aggressive. Biochemical is where we're measuring the M spike or the free light chains, and they're just starting to come up, but people feel otherwise well. I think in those scenarios, we're trying to add oral drugs to compensate. So if you're on Revlimid and progressing, we can add Ninlaro, we can add panabinostat, we can add selinexor to help control that. For people who are having more aggressive progression of disease, their kidneys are starting to feel the pressure or the more anemic or their calcium is going up, there's where we have to have a more complicated decision. So we still are having the availability of the clinic and all of its resources and just continuing what we would do otherwise, but just take more precautions.
Okay. Well, I want to jump into a question so I don't forget it going forward, because you talked about different options, and it's probably better if we talk about it later, but I don't want to forget it. So you mentioned selinexor, and I know because it was just barely approved, there are a lot of doctors that don't understand how to use it and how to mitigate the side effects that you have with selinexor, and if they're managed properly, it can be just fine. So do you want to review a little bit about that so that patients, as they go and talk to their doctors, like, I may want to try this, and the doctor, I've had community doctors will be pushed back and go, well, I don't know how to use this drug yet.
No, I think that's a really critical question. So selinexor was originally approved July 3rd of last year. It was approved based on the STORM study, and the STORM study looked at just giving selinexor and dexamethasone as pills with no other myeloma regimens. And in order to achieve a high enough response rate to get the drug approved, the drug needed to be given twice a week at 80 milligrams. However, it's a little more toxic to give it that way, and it's far better to give it once a week. But if you give it once a week, you have to mix it with another myeloma drug so that you get enough synergy and it works even better. And this actually comes true from the Boston study, which was just read out as positive a week or so ago, where we combined selinexor with Velcade and patients do amazingly well. And instead of getting 80 milligrams twice a week, we give 100 milligrams once a week. So optimally, the drug is given once a week, and the dosing is different depending upon which drug you give it with. If you give it with daratumumab, carfilzomib, or Velcade, it's 100 once a week. If you give it with pomalidomide, it's probably 60 once a week. With Revlimid, it's probably 60 as well. Sometimes pomalidomide, you can put it up to 80, but 60 is probably the better dose. The other thing to mitigate it is it's far better to be proactive than reactive in terms of side effects. So we find that if we're very aggressive about preventing side effects, they happen in much fewer patients as opposed to dealing with nausea or other problems after they have it. So we give a combination of medicines to prevent it, things that are a little bit out of the box. So Varubi is a drug we use quite often, which is similar to Emend, which some people may take. We give drugs like Zofran and steroids. And another one is Zyprexa or olanzapine, which was originally marketed as an antipsychotic drug, but actually has a lot of great efficacy to prevent nausea and GI side effects. And again, these are all pills. So what we are doing is giving people many prescriptions. Unfortunately, there becomes a higher pill burden in this case, but it's a way to prevent symptoms and control the disease.
Mm-hmm. And so if that study, the Boston study I know, is using selinexor with Velcade and dexamethasone, would you consider using Nilaro in place of that with selinexor and dexamethasone?
It's a really great question. There's not sufficient data that I've seen yet with Nilaro, but in the STOMP study, which combines selinexor with a whole bunch of other drugs, we have data with selinexor and Revlimid and selinexor and pomalidomide. So the best data so far as an all-oral combo with Seli would be selinexor pomalidomide index, and really great data coming out of the STOMP study for that.
Okay, so that might be something doctors might feel more comfortable applying for a temporary situation.
Absolutely.
So yeah, that's a really unique approach. And same question for panabinostat. Like, what do you combine that with if you're thinking about using panabinostat? Mm-hmm.
It's a phenomenal question. So, the panabinostat was approved in about 2014, 2015, and it was approved based on the Panorama study combining panabinostat with Velcade. There have been another number of smaller studies now giving it with drugs like carfilzomib, and more recently looking at combining it with IMiDs, Revlimid and pomalidomide. And we've actually at our center been using these combos for quite some time with a lot of success. There are a few unique things you have to look out for to make things optimal. The main thing about panabinostat is in the original study, it was given 2 weeks in a row and 1 week off. And we found that it caused a lot of GI issues, mostly diarrhea. But if you give it every other week, it's actually tolerated way better. So I saw a patient yesterday who's having progressive disease, and I put him on Revlimid, panabinostat, and Dex. The panabinostat dosed every other week, and he's going to go locally for blood work, and we'll review it by a video visit every 2 weeks to monitor things. So because the drug actually resensitizes, and we have data showing this, that if you become refractory to a drug like Revlimid or pomalidomide, panabinostat can actually resensitize the tumor and make those drugs useful again. So even if you're refractory to some of these drugs, we can actually still recapture you with an all-oral regimen.
Wow. So this is just amazing, because the creativity that you're already a myeloma specialist, and we highlight all the time how patients need to go talk to a myeloma specialist to get their care crafted. But in moments of, distress and crisis that we're having right now, it's even more important. So when you think about, you mentioned telemedicine, can patients reach out to a new myeloma doctor if that, let's say they get their care locally and they have somebody helping them kind of craft their treatment strategy that's local, that may not know that much about myeloma? Are there telemedicine options to get a second opinion with somebody like you, or how is that all working?
100%. So I literally saw 2 patients yesterday that I've never met before. I saw them via telemedicine visit, and when I got off the phone with them, I called their local doctor to discuss all the details and emailed them my notes. The reality is that much of what we do is reviewing charts and having conversations, and a lot of this can be done via telemedicine. So we have new patient visits that are already set up that we're converting them all to new patient visits unless there's some outstanding reason. And there are a select group of people who still need to come in if they're having severe complications and we need to give them aggressive medicine immediately. But if it's for a second opinion, absolutely. Reach out to any of the major myeloma centers. Many of us are already set up for telemedicine, have been doing it for a long time. Happy to do that.
Okay, and we have a myeloma crowd directory as well on our website. So if you go to myelomacrowd.org, under the Find tab, you'll see a list of myeloma doctors. And if anybody has trouble getting in touch with some of the doctors, please just email me at info@proudcare.org, and I'll make sure that they get the message. So let's talk about that, because you mentioned for people who still do have to come in. So people are coming in for infusions like daratumumab and carfilzomib, or even Velcade, or things like that. Do you want to talk about potential strategies patients could think about in terms of their timing and their locations and the frequency and all that in a little more detail?
Absolutely. No, absolutely. So I think it's drug by drug. So daratumumab luckily has a very long half-life. So there's a general step up. The way daratumumab works is not exactly like a normal chemo where you give more and it does more. As an antibody drug, think about it that every tumor cell has a lock, and the daratumumab is the key. And as you build up the levels in your blood, every lock has a key in it. And by dumping more keys, you don't necessarily make things better. And these keys hang out for a very long time. So what we're doing for some people is accelerating things and really getting them to a less frequent dosage sooner, instead of once a week, pushing to twice a week, or even once a month. And again, many patients who are seen at a variety of different centers or go for second opinions, our general recommendation is that if there's a drug that's commercially available, to get treated locally. And we are more than happy to continue to work with all of the local doctors to ensure everything is going smoothly. For elotuzumab, another IV drug, many people are still giving it the classic way from the original study, which was 10 milligrams per kilogram every week for 8 weeks, followed by the same dosage every 2 weeks. With more recent studies, we know that we can double the dosage and halve the visit time. So you can push it up to 20 milligrams per kilogram and give it once a month. And this allows people to continue on effective drugs, but get them less frequently. Velcade, a lot of our Velcade, we're switching over to Ninlaro because there's very similar efficacy and it's a very useful drug. Carfilzomib, what we're trying to do for patients who require that drug is many of the original protocols gave it twice weekly. We're reducing that to once a week.
Yeah, I have seen a lot of studies talking about once weekly carfilzomib dosing and lower side effect profile and things like that too, and just as efficacious. So it seems like that would be a really great option.
Absolutely, and we actually know that as you crank up the dose, you can sometimes even get better responses. So the recent ARROW study, where we compared the classic twice-a-week dosing at 27 versus once-a-week dosing at 70, the once-a-week dosing was actually superior. And again, in times like this, that combined with fewer visits to a doctor's office is very advantageous.
Mm-hmm. We're going to learn a lot using all these different and new combinations. So I think so. So let's talk about isatuximab as well. So isatuximab was just approved, and it's similar in the same class as daratumumab. What's your opinion on the use of that?
Isatuximab is a phenomenal drug. In the lab, it appears to be slightly better. When we actually give it to patients, it's hard to say. It's very, very similar. One of the big advantages to isatuximab, especially during this time, has to do with that first dose. So many people who may be listening, they know that first dose of daratumumab can take 8 to 10 hours. The second dose can be 6 to 8 hours. Now, we do have a subcutaneous version of daratumumab that's going to come along any day now, but we're not there yet. The benefit of isatuximab is that those first couple doses, instead of 8 to 10 hours, the first one's like 4 hours. And instead of the second one being 6 to 8, it's more like 2 to 3. So one of the great advantages right now is it's tolerated very, very well, very efficacious drug, and reduces the amount of time you're in a clinic.
So interesting. And for these, I mean, a lot of times what you're doing with your patients who you're doing telemedicine with, you're sending the doctor's orders. And I think a lot of patients sometimes don't know that you can get a consult with a myeloma expert and you don't have to get your treatment there necessarily. It's like you don't have to drive into New York City and get treatment there. You can get treatment at home, and you can do what you did with the other patient, which is just craft the strategy, tell the local doctor what to give and how to give it. And I think patients just need to be reminded of that.
100%. The one thing that I would add that we're very much encouraging at Mount Sinai is, just as it's always a good idea when you come to a physician's visit to bring somebody else with you because you never pick up everything, for telemedicine visits, it's no different. So we're very much encouraging that when we do the telemedicine visits, if there's someone else in the house to listen in, great, or to kind of conference in somebody else, because we know that in these stressful times, no one's going to remember everything. So, the same thing for regular appointments. Having somebody else listening to the information is very much encouraged.
Yeah, I totally agree. There's a lot that's covered, and it goes quickly, and you don't necessarily catch everything because you're thinking about other things like, not leaving your house and stuff. So, yeah, it's crazy. Okay, so when you talked about, let's go back to stem cell transplant. You touched on it at the beginning about potentially delaying transplant for those people and maybe having a few more cycles of your induction therapy and kind of pushing it out. If for those who have a planned transplant, that's kind of your strategy, it sounds like. For those who are just finished with transplant or are high risk and really need transplant as one of their options, what do you suggest?
So again, this is really, at the end of the day, this is a patient-by-patient discussion, which is what we're doing with everyone. In general, even in the higher risk settings, it is still, if you have an excellent response to induction, there's still some people who question the role of transplant. I think that the two questions that we think are is one, do we already have stem cells? Because if you already have stem cells, the timing is a little more malleable. If you don't have stem cells, you have to make a few other decisions. So I saw a lovely person the other day, telemedicine visit, receiving carfilzomib, lenalidomide, dexamethasone induction, amazingly well. We want to hold off on collection right now. So we know that drugs like Revlimid, if you have too much of it, it makes it harder to collect stem cells. So for this gentleman and many others, we're dropping the Revlimid, continuing them on their Velcade or carfilzomib or Nenbaro or carfilzomib, and just letting them remain in remission with regular blood work, following them closely until we kind of figure out the optimal risk-benefit to collect cells. For transplant, for people who already have cells, the same thing. If you already have stem cells and you're on a regimen that's working, we encourage people staying on that regimen. And we know that this is not an unreasonable strategy. So there's an ongoing trial called the Forte study, really great study. It's 3 arms. In one arm, people get, with newly diagnosed myeloma, carfilzomib, Cytoxan, Dex plus transplant, carfilzomib, Revlimid, Dex plus transplant, or carfilzomib, Revlimid, Dex, no transplant. They just stay on it for 12 cycles. And in both cases, the KRD arms did better. There's definitely a hint that the people who have high risk do better with transplant. But continuing on your induction for more than the 4 to 6 cycles, there's nothing wrong with that. And for many people, it may even optimize things for when they do go to transplant. So we're really trying to avoid it unless it's the only choice that really makes sense.
So we talked about the immunotherapies. Are there any other specific drugs that you want to discuss that in terms of administration or differences in administration during this time?
No, I mean, I think the only other drug that we're talking about very heavily is IVIG. So for many people who have myeloma, they get multiple infections. And one of the ways that we kind of boost your immune system or increase your normal immune globulin level is to give a drug called IVIG, or intravenous immune globulin. Now, there are some risks and benefits. The main benefit is, of course, that it helps protect against infections. One of the potential risks is that if you're getting it once a month, that's an extra visit to the doctor. So, again, we're discussing this on a case-by-case basis, and one of the ways we do this is measure your IgG, and we know your history. If you have an IgG level, and that's your immunoglobulin level, that's 200, which is extremely low, and when you're off the IVIG, you end up in the hospital with pneumonia, you need to continue IVIG. If your IgG level is normal and you haven't had an infection in 2 years, we're going to hold that, especially now that we're getting into some of the warmer months. So some of the non-COVID infections like RSV and influenza are going to go down.
Right. That makes a lot of sense. Okay. Can we talk about just weakened immune systems in general?
So,
do any of the medications, I know, like, if patients are on a lot of myeloma therapy for a really long period of time, sometimes they can have a weakened immune system. So are there any drugs that patients should kind of steer away from, or what's your opinion on that?
So, I mean, I think that's a really, really great question. And myeloma is, of course, the hardest place to answer because myeloma itself, the bad cells, weaken the immune system. And when we give some of our drugs, they may weaken them further. The quick and easy answer is it's a case-by-case basis. But there are some strategies that we're taking in some people who are on many different drugs. Let's say they're on daratumumab, Revlimid, and dexamethasone, and have been on that for a very prolonged time. We may stop the daratumumab literally to avoid them having to come into the hospital, but the other benefit is that it does relax some of the pressure off the rest of the immune system, may give them a little bit of immune recovery. So it's a win-win for some patients who it's clinically appropriate to back off on their therapy. So, yeah, I think the best thing we can do is as a case by case, really, personalized medicine is really this. Who needs to still be on the aggressive medicine? Who have we just kind of kept on aggressive medicine because that what seems to be the right thing, but now may be suboptimal?
Mm-hmm. Well, you're weighing risk and benefit, right? So, and you have to do that based on that individual.
100%.
Yeah. Let's talk a little bit about drugs like immunotherapies that are currently in clinical trials, because this situation is having a huge impact on clinical trial participation and joining new clinical trials, or even releasing new clinical trials. Do you want to just share your perspective?
Absolutely. I just got off of a phone call about 20 minutes ago or just before this about clinical trials, and it's complicated right now. So for those who don't know, clinical trials are things that we do when a drug is not yet approved, and we need to run them through testing to make sure that they're safe and what the right dose is for patients. This affects people at a lot of levels. One is people who are already on clinical trials. People who are already on clinical trials, if the drug is working, we want to continue it. Every trial has a list of requirements that the FDA and the trial puts you through, and the FDA has actually released some guidelines to let us know that, do what's appropriate. Meaning if you're on a clinical trial and you're responding well and it tells you that, you need to come every week for blood work, but your blood work has been great for months, we can back off. We don't need to do it every week. And the FDA is going to let us know that that's okay in the long run. So we're trying to make adjustments, but if you're responding well to a clinical trial, we're trying to keep you on it. For people who are going to go on clinical trials, the landscape of trials in myeloma has changed across the last decade. So a decade ago, most of the trials were for people with no other options. Nowadays, many of the trials that we put patients on, there are other options. And if there is a standard of care option that is at least as good, we're going that direction. So we're really trying to limit people going on to clinical trials right now kind of across the board. Again, the handful of patients who really need it because there's absolutely nothing else available, we're evaluating on a case-by-case basis. But the reality is for many people, and obviously not all, but for many people going on trials, there are other options. I think the big thing this is impacting is a lot of people are very interested in going on to CAR T studies and bifunctional antibodies. And again, the same principle applies where if we have another option to put you on in the meantime, we will, because the type of immune suppression you get with a CAR T may put you at unnecessary risk for infections during this time.
How long does that typically last with CAR T?
The immune suppression?
Yes.
So there's two types of immune suppression that we get with CAR Ts. One is cellular and the other is humoral. Cellular is where your white blood count is low. And for some people that can last months. And the other is humoral, those immunoglobulins or antibodies that you make. That can be low for even longer. So for some people, they have a good amount of immune suppression that can last for 3 to 6 months. And again, it's not that is an insurmountable feat, but right now, if we were going to put someone on a CAR T at their first relapse, instead of giving them something like daratumumab and Revlimid, or Revlimid and Ninlaro or something like that, we may opt for a standard of care at the moment.
So interesting. So is the situation the same for the BiTEs and the antibody drug conjugates, in your opinion?
Absolutely. So it's the same thing because the main risk of CAR Ts is the cytokine release syndrome, where when we put the CAR T into the patient, it activates the immune system and releases all these chemicals we call cytokines, and you can have high fevers, low blood pressure, confusion. It can be very serious. The BiTEs have the same risk. So many of the trials right now with bifunctionals or BiTEs require multiple admissions to the hospital to monitor for CRS. We don't want people being admitted 3 times in 3 weeks to the hospital right now. So those trials are shut down. The antibody drug conjugates are very interesting because we're on the cusp of at some point in the next 6 months having belantamab mafodotin, this big BCMA antibody drug conjugate approved. So I think at the moment we're anxiously awaiting that drug to come out as another tool in our tool belt. But it's going to hold up those trials as well for the moment. mostly from the requirements that trials need to keep you on study.
Mm-hmm. Yeah. Okay. Well, it's really shifting a lot of things for a lot of different people. And the development that's happening in myeloma is so stunning that I just don't want that to slow down, because we do need these new therapies. But well, there's a lot to think about.
Absolutely. No, it's something that's absolutely critical. I mean, one of the things that we're kind of hoping is the next few drugs that are going to be approved, belantamab and BB2121, a lot of this is just waiting for the final information to kind of reach significance and be filed with the FDA. And although the FDA is going to be spending much time working on COVID-related therapies at the moment, we're hoping that this doesn't slow up those approvals and that we can get them out to our patients who need it as soon as possible.
Right, because they're pretty close to being approved, it sounds like. So let's talk
Absolutely.
about issues that patients should consider. So who is specifically at the highest risk for developing this virus in terms of myeloma patients?
Absolutely. So, it's something that we have to kind of extrapolate from the data we have. The data that we have, and doctors are joining from all over the world to share pieces they have, is literally changing moment to moment, hour to hour. And some of the biggest data we have comes from the Hubei province in Wuhan, China, where they kind of published this paper on March 9th in Lancet, which is this big journal, talking about who really gets sick. And it seems that the people who really get the sickest are people over the age of 80 or people who are over the age of 60 who have significant comorbidities, the biggest one being lung issues. So for people who are older or over the age of 80, those are the people who are at higher risk, who really should practice social distancing as much as possible. And I always tell them, for essentially all these people, they spend their lives helping people, helping their families, helping their friends. This is a time to let us help them. Have your neighbor, have your kids send food to you so you can social distance. Or for people who are over the age of 60 who have significant comorbidities, especially lung. So people have underlying COPD or asthma. Those are the people we really worry about. So if you have underlying lung disease, the same thing applies. You have raised friends and family throughout the years. It's time to lean on them to help you. And I think those are the big watchwords we're trying to convince everyone of.
Okay, great. And what about other normal comorbidities that come with myeloma, like kidney issues, or are you seeing any greater incidence or concern for people like that?
So the one thing that is very much in question, is being debated quite a bit, is, when the COVID virus started, one of the big questions that everyone was asking is, how is it that older people seem to be getting sick, but younger people don't? And again, it's not that younger people don't get sick. They can still get it and they can still pass it along. But the very severe illness seems to be limited in younger people. And one of the theories, and again, this is early on and the data may change tomorrow, is that it relates to an enzyme called ACE, angiotensin converting enzyme. And this is a chemical that's in our body that relates to our kidneys and blood pressure. In fact, many people out there may be on ACE inhibitors. If you're on a drug that ends in the word pril, enalapril, quinapril, those are ACE inhibitors. And it seems that some of the people get sicker. This mechanism may be overactivated. But the question we all ask is, well, should we all stop our ACE inhibitors? And the American College of Cardiology said no. There's no evidence to stop them. So the recommendation is not to stop ACE inhibitors. In terms of other drugs to take or avoid, there's a bit of a conflicting data about NSAIDs, drugs like Advil or ibuprofen, Relieve or naproxen. Originally, the WHO released a statement that patients should avoid Advil or NSAIDs and take Tylenol instead. They just released some statement today saying that that may be in question. They don't know that for certain. In general, patients with myeloma should avoid NSAIDs if at all possible anyway. So definitely issues, Tylenol right? Was preferred. Exactly. And what it turns out is what we think is that COVID, there's a Goldilocks phenomenon, meaning you want just the right amount of immune system. Too little. In the case of if you give things like NSAIDs, NSAIDs actually affect the immune system because they're anti-inflammatories, and inflammatory cells are what our immune system is. So if you take too many NSAIDs, the concern is the virus can take root. On the flip side, an overactive immune system may not be ideal as well. In fact, one of the drugs that we're using in advanced COVID cases is a drug we use in people who get CAR T therapy. So the cytokine release syndrome that people are at risk from with CAR T therapy, if they get it, it's basically when their system gets too much of a chemical called interleukin-6, and that really drives these high fevers and low blood pressures. And we have a drug called tocilizumab that blocks that. So people get overactive cytokine release in CAR T therapy, we can shut it off with tocilizumab. It turns out the same chemical that's elevated in CAR Ts, in people who have COVID, elevation of that compound is correlated with a worse outcome. And there was a paper released from China recently that 20 patients who were severely ill, essentially all of them had massive improvement when given tocilizumab. Now, it's not ready to give to everyone, and it's not clear that everyone needs it, but it's another tool in our armamentarium for people who get very sick.
Yeah, I read the paper on that. That was so interesting.
Yes,
that's being tested because it had that myeloma connection with cytokine release. So interesting. I think just the world is searching for solutions right now. So it's fantastic. Yeah. Should myeloma patients be proactively tested at their myeloma visits if they're there already, if they think there might be some kind of symptom? What do you suggest in terms of like what symptoms should patients watch for and things like that?
Absolutely, and this is great. And the reality is I'll give you the answer today of what I say, but it's going to change in the next few days because of the guidelines for testing are literally changing moment to moment. And depending upon where you live, the availability may be very different. So obviously, if you have any of the classic signs of COVID, which are fevers, shortness of breath, dry cough, you should be evaluated and tested. My recommendation would be is to call your local physician's office or urgent care center and see if there's a way to be tested outside of an emergency room. It's optimal to avoid emergency rooms if at all possible if you're not very sick. Obviously, if you're having significant trouble breathing, lethargic, really sick, then you have to go to the ER. But if you generally feel well and you take your temperature and it's a little bit up, you have a little bit of a cough, try to do this outside of a hospital or clinic setting. See if you can do it in urgent care or in some of the drive-by centers that are being set up. If you're already at your physician's office and they're able to test you, there is no downside to testing and there's plenty of upside. And much of this comes out of data that was looked at in the province of Vo in Italy, where they tested everybody. And it turns out that even asymptomatic people have it. And the benefit of knowing is that if you know you have it, you'll avoid other people from getting sick. But again, the ability to test is going to be different from place to place and moment to moment. So obviously, if you have symptoms, get tested. If you're at a regular visit, you can ask. And if they have the availability to, there's no downside to being tested.
Yeah, and it sounded like from some of that data that was coming out of Italy that you could have it for up to 5 days or something like that without having any symptoms. So that's part of the issue is that when you don't know, you're out and about and, causing issues when you don't even know it.
And that's part of the reason we're seeing the steep rise is because it can be up to 5 days. For some people, it's even longer until they have any symptoms. And I think social distancing is really reaching appropriate levels now, but unfortunately the last couple of weeks it's taken a little bit of time for everyone to get on board with this, so people may have been infecting others. As soon as there's more testing available, we should all be tested as soon as possible. And actually, someone had chimed in on a Facebook post about this. Mount Sinai actually just published a paper. The infectious disease and microbiology group at Mount Sinai developed the first antibody test for this. So the testing that's currently being done is through what's called a PCR, polymerase chain reaction. And basically it looks for little bits of the virus. And that's it. It tells you have a little bit of the virus, none of the virus. But what this test that was just developed at Sinai and is going to be rolled out probably within the next week is looking for antibodies. And there's a lot of advantages of doing this. The antibodies can be detected even after only a few days of symptoms. So it's a very efficacious test. It also lets us know who's immune. If we know who's immune, we can help work on developing vaccines and preventative strategies from that. The other issue is once healthcare workers, we know that someone has had it and is immune, we can send them back to work to help others. So this is a major step forward, and we're very happy about it.
Well, we need that test right away.
I've been talking with the leadership. It was just developed like yesterday. They published the paper, and it's possible we're going to roll it out as soon as this weekend, which, I mean, that's one of the things. You know, some of the testing that's being done in clinical trials with a drug called remdesivir, which was used to treat Ebola in Nebraska, most of the time trials like this take a decade to open up, and this is being done in a matter of days and weeks. And you know, through a horrible thing, it's amazing to see the medical community. And when I say the medical community, I'm not just talking about the scientists, nurses, and doctors. I mean, even the people who come in to clean the floor, the people who serve the food, everyone is taking a risk. They're all joining together, along with the FDA, to get therapies out as quickly as possible.
Yeah, it's amazing and stunning. And so it's just wonderful that this is happening. I know on the waiting period, does that test have any certain wait? So my son got tested yesterday, and there's like a 5-day waiting period before he knows. So he's kind of just hunkering down before he knows if he has it or not.
Yeah, so we're speeding up all the tests. This, I think, has a less than a 24-hour turnaround, but don't quote me on that because this was developed within the last week. So, you know, getting it up to commercial grade is a little bit, you know, that is all being rushed, and it'll be open within the next week or so, potentially even by this weekend. There's still a short turnaround, but I think across the board, even the viral test, we're getting shorter and shorter turnarounds.
So you talked about some symptoms that are serious enough to go to the hospital. So shortness of breath or being overtired, seriously overtired. Are there other symptoms patients need to watch for? Does it happen quickly? Do you need to act quickly? How much time do you have in doing that? And then you talked about going to the ER, but if you test positive and let's say you don't have serious symptoms, you don't need to go to the hospital necessarily, who should treat you? Should you go to the local clinic? Should you call your myeloma doctor and go there? What should patients do?
I think that one of the things we're all aware of is that there's a lot of unknowns. So the first thing I would say is when in doubt, call. If you have a temperature at home of 99.9 and you're not sure, call. If you're feeling relatively well, call. It doesn't matter if it's 2 o'clock in the morning. We don't want people being stoic because what may be fine to wait at one point may be more urgent later on. So close contact, and you can call anyone. You can call your myeloma doc, your primary care doctor, and we may end up working together. So someone called the other day who lives quite a bit of ways and said, where can I go get tested? And I said, your local doctor will know the answer. He knows all the hospitals right around there. I don't know all the hospitals in the small town in Tennessee. So I think in general the symptoms have not been coming on as thunderclap, like you're fine 1 minute, not fine the rest. Unfortunately, most people have experienced the flu, so I think it's somewhat similar where you start feeling a little bit unwell and all of a sudden, over time, symptoms get worse and worse, and I think at the end of the day, you know your own bodies. If you know that something is really wrong, you call. If something is really, really wrong, that you can't catch your breath or your fever is 105, that's not necessarily time you can wait for a call back. You may need to go to the ER. But all else being equal, if it's just a little bit of a cough, a little bit of a fever, and you otherwise feel well, call your local urgent care, call your myeloma doc, your primary care, and we can all work together to find the best setting to be tested to avoid hospitalization if at all possible.
Yeah, great advice. So what is a typical treatment for COVID-19 for a myeloma patient, and is it that any different than the normal population?
So we've developed some algorithms here, and we're trying to work them out because the data is changing day by day. So that IVIG drug, which is unclear if it helps or hurts, if your immunoglobulins are very low, we may give you some IVIG. What is arising is a drug called hydroxychloroquine, more commonly known as Plaquenil. That appears to have some really good effects in people who have COVID-19. So depending, if you come into the hospital and you're short of breath and you're requiring oxygen, we may up the ante and give you Plaquenil. which can modulate the immune system. The steps beyond that become a little more complicated, and it's case by case. So there's, if you have, one of the things we're able to do here is measure those levels of IL-6, and if you're starting to have more trouble breathing and your IL-6 levels are high and clinically appropriate, we can give tocilizumab. And we're even part of about to open a clinical trial, but have access potentially to compassionate use if needed. There's a drug called remdesivir. Remdesivir was a drug that was designed to treat the Ebola virus previously. It's available on limited access. So for patients who are unfortunately very sick in the ICU, that's an option. And then the other options are kind of up in the air and case by case. So some of the older HIV drugs, ritonavir and lopinavir, may have some anti-COVID activity. That's being looked at case by case. Chloroquine, which is similar to hydroxychloroquine, may also play a role. Unclear about steroids, whether or not they help or don't. Again, if you're having trouble breathing because there's so much inflammation in the lung, we may give steroids, and unfortunately myeloma patients know steroids better than almost anyone on the planet. But those are the main medicines we're using right now.
Okay, great. And if somebody's seeing a local doctor and it can't access their myeloma specialist for some reason, what do the other doctors need to know about a patient's myeloma when they're being treated for COVID-19?
So that's an extremely important question. I think that's something that I'm glad you asked, because it oftentimes falls by the wayside. What we're doing, again, is case by case. For the majority of people who develop COVID-19, we are stopping their therapy. Now, that may not be correct for everyone. So what I would highly recommend is people don't take it upon themselves to stop, but to reach out to their oncologist, their myeloma specialist, and discuss with them, what's the risk and benefit. But for many patients, we're holding the therapy to allow their immune system to kind of take care and part of managing the virus as much as possible.
Have you had a lot of patients test positive in your myeloma clinic?
We have not had many. We have had a few that we've had to manage with this, and that has been our general strategy.
Yeah. So these are just such crazy times. What can patients do to stay healthy or fit if they're using, normal social distancing? But I think people need to make sure that they're not socially isolating also, like both physically and mentally. Do you have any recommendations about that?
Absolutely. So the three general principles of life, eat well, sleep well, and get exercise, apply whether you have COVID-19 or not, myeloma or not. Those are three very important things from a physical standpoint. So eating well. As many of us are socially isolated, this is not a time to just eat chips on the couch. So healthy eating is really important as much as possible, obviously within reason. If it's difficult to get some of the fresher things, canned vegetables are oftentimes a better thing than having a box of donuts. So healthy eating is important. Sleep is very important. Everything is made better by good sleep and worse by no sleep. So sleep as best you can. If you need something to help you sleep, reach out to your care team, and we're happy to prescribe something to help people to get to sleep, because our minds start to race when we lie down at night after watching a whole day's worth of craziness on the TV. And exercise. Exercise is just a generally good thing, physically, immune-wise, etc. There are many ways that, even though we often don't, to exercise at home. So what my wife and son have been doing, along with our daughter, is doing home yoga. There's many stations on YouTube or on the television to show you how to do home yoga and home exercise. There's even some funny ones on YouTube, which I wouldn't suggest, where people put oil down on their kitchen floors and use it like a like a treadmill. I wouldn't suggest that, because you can slip and hurt yourself. But there are many low and no impact ways to kind of keep things healthy. The other thing you brought up, which is something we're hyper aware of and maybe not be optimizing, is mental health. Mentally, this takes an enormous toll on a group of people who are already facing a mental toll that I can't begin to imagine. So, doing what you can to keep your mental status up and your mental health up is crucial. If you need medicine to help, it's there. One of the things I highly suggest, it's 2020. FaceTime. Call people, FaceTime with people. If there's someone you haven't talked to for a while, call them. This is the time to make sure that we stay, we're all interconnected by our phones. Now's the time to use that to its maximum yield. You normally would call your kids once a week. Call them once a day. Everyone's at home. Everyone has time on their hands right now, except for the people on the front lines. Take the time to call your loved ones, call your friends, engage with people. There are many ways technology can help us.
Yeah, that's amazing. Great advice. Terrific advice. Well, I'd like to transition to some caller questions so we have time for that. If
Sure.
you have a question for Dr. Richter, please call 347-637-2631 and then press 1 on your keypad, and I'll be able to see if you have questions. So let's see. Caller from 264-7609. Go ahead with your question.
Hi, Jenny. It's Jack Aiello. Great question.
Hey, Jack. How are you?
I'm doing fine, and great answers from Dr. Richter. Since I can no longer ask him the question about eating chips on the couch, I'm going to ask a little bit more about clinical trials. I know that Bella and BB2121 are close to approval. Are those trials that the FDA would be looking at? I hope they're already fully accrued.
I think even so, it's complicated because both of those drugs or both of those treatments have multiple trials. So all of the Bella trials are called DREAM. There's DREAM 1, 2, 3, 4, 5, 6. And all of the BB21 are called KARMA 1, 2, 3. The main studies are accrued, and we're just looking for follow-up. I can't answer the question of is the infection going to stymie the one little piece of data that they need. My guess is that it will not, that at this phase where those drugs are, where they're literally due to be approved within this year, hopefully within the next couple of months, that it's simply a question of the final follow-up from patients, the data, and all the paperwork that needs submission to the FDA. I know that all the companies are working very closely with the FDA to minimize any impact COVID will have about getting these drugs up and running. That being said, the one thing that I would think about is, let's say they were both approved tomorrow. Bella is a drug that gets manufactured, shipped, and given in any office that can give infusions. BB2121 is a little more complicated. It requires pheresis. It requires manufacturing of the cells. So it's, even in normal conditions, it may have taken a little bit of time to get that up and running. But in speaking with the people at BMS Celgene, they're still highly dedicated to getting this in the hands of patients as soon as is appropriate.
And if a patient were in the middle of a clinical trial, I gather that if they were diagnosed with COVID-19, that you would end up stopping treatment associated with that trial?
It's a really great question. The answer is not necessarily. It depends upon what the drug is, how bad the infection is, and the rules of the trial. So what most trials have in the protocols is guidelines to say if something bad happens, you can hold the drug, but oftentimes it'll say if the drug has to be held beyond, let's say, 4 weeks, you can't go back on the drug unless the sponsor says okay. So under normal circumstances, let's say you're on a clinical trial, you get a pneumonia, and you're off for 4 weeks, the study may say, listen, you've been off for 4 weeks, we have to stop it. I think in this setting, with everything up in the air, the FDA has been really gracious about letting us know that we need to do what's in patients' best interest more so now than ever. So case-by-case basis, but I think that if the infection is mild and people get over it, there's a good chance that we can get them back on study. So I wouldn't just stop study drug, but again, this is really case-by-case.
Thanks so much for your answers, and I look forward to the next time we see each other.
Absolutely, sir.
Okay, great. Okay, we have many, many questions, so we'll ask everybody to limit their questions to just one. We have caller at 391-6431. Go ahead with your question.
Yeah, hi, this is Art Lamus. I previously was a patient of Dr. Richter, and there's a lot of contradictory or amorphous information about what's how the disease can be COVID-19 can be contracted. And one of the studies said that, or one of the doctors said that the disease lingers in the air, the virus lingers in the air. Can you get COVID-19 from breathing it in an environment where you've been exposed to the virus in the air?
So I think you're asking the really important question, and I would be lying if I could tell you exactly what we know, because I think you put it perfectly. The information is somewhat conflicting. It is very amorphous. One of the things that we do know about COVID infection is that apparently the viral load matters. And what that means is there's some diseases where the amount of virus in you doesn't really seem to mean too much. You either have it or you don't, pregnant or not. But in COVID, the amount you have seems to matter. So if you are literally sitting right next to, if you're living with somebody and you're literally around them all day long and get continual viral particles into you, that is probably far worse than even if there's a small amount that you inhale that has been out there. Now, again, the data is changing daily. I think that in general, when people go out, especially when you go out to markets, grocery stores, wearing masks is a great idea. The surgical masks are just fine. You don't necessarily need an N95 mask. But I think you pointed out perfectly, we don't have clear data and guidelines right now. And as this moves on, we may learn more. So what I'm doing to protect myself and my patients is you go out, you wear a mask. But in general, we know that people who get higher viral inoculum from being in close quarters with people seem to have worse outcome.
Okay, thank you.
Okay, great question. Thank you so much. Great answer, too. Okay, caller at 391-643. Oh, we just did that. Sorry. Caller at 468-8552. Go ahead with your question.
Hi, Jenny. This is Cindy. Hi, Dr. Richter. This is Cindy Shimoleski.
Hey, Cindy.
I was supposed to be there today talking to you in person, but I think it's so much more valuable. Plus, they wouldn't have let me in the building anyway. So my question is, I'm reading a lot about different clinical trials that are testing the effectiveness of different drugs, just like you had said earlier in the show. Now, are those drugs only being given through a clinical trial, or are they being given whether or not you're in a trial? And would you recommend if a myeloma patient does get COVID-19 to try to make it to the research centers instead of their community hospitals?
All great questions. So many of these drugs are not very ubiquitous. So if a drug has no real FDA approval, it's really kind of hard to give. So remdesivir is not readily available. We can't just give it to people. Tocilizumab is more available, so we can make clinical decisions at the bedside, and if we think the benefits outweigh the risks, we can give it. But again, it's a more severe step. Hydroxychloroquine is a drug, Plaquenil. There are probably many people listening and out there, family members that are already on this drug. So that drug's a lot more readily available, and I think we're more willing to give that in a place where we just don't know the answers. So when drugs are, sitting in shelves that we have ready to go, more of an inkling to give them. Some of them do need clinical trials, but what's really great is some of the drug companies are opening up, outside of trials, compassionate use programs. So much in the same way that we have compassionate use programs for myeloma. For example, right now, belantamab is available through compassionate use and expanded access programs, even outside of a clinical trial. Same thing is being done with some of these drugs. And what was your last question again? Oh, to go to a center.
Right. Should I try to make it to a research center or go to my community hospital?
So it's a complicated question. I think depending upon your symptoms, it's, obviously if someone is very, very sick, you need to go to your closest center, because time to getting those supportive care meds, the oxygen, the CAT scan, the IV fluid, those are critical and those can be given anywhere. I think that if you are otherwise feeling well, then this is a conversation you have with your care team, because it's a great question. If you live 10 miles from your normal ER, but 15 miles from your myeloma center, it's an easy decision. if it's 10 miles and 50 miles and you're not feeling well, you shouldn't go down there. So the majority of what we're doing can be administered at any center. So the default answer is closest, but if you're feeling well, it's a great question to ask your care team.
Okay, thank you very much, and hopefully I'll get to see you soon.
I'm looking forward to it.
All righty. Bye-bye.
Okay, great. Thanks, Cindy, for your question. Okay, caller 84. Do you have a hard stop, Dr. Richter, at the top of the hour? Or do you mind
take a few more minutes?
It's no
problem. Oh, we'll answer a few more, sure.
Okay, great. Okay, great. We have caller 847-5748. Go ahead with your question.
Hi, Dr. Richter. So you spoke about IVIG as a potential measure to prevent infection, although I think you said for some patients it's recommended, others it's not. What about Neulasta? Would that work for antiviral, or it's only antibacterial?
So Neulasta it's a really great question. So, we talk about the immune system, and there's many, many parts of it, and I wish Han Cho was here, who knows more about the immune system than any person on the planet. In broad terms, there's the humoral and there's the cellular. The humoral is the antibodies that IVIG helps with. Neulasta helps with the cellular immunity, increases your white blood cell count. It tends to help increase your neutrophils, which tend to do more to fight off bacterial infections. However, with any virus, you run the risk of a superimposed bacterial infection. So it's not uncommon that people get something like the flu or rhinovirus, and the doctor still puts you on antibiotics because you get a superimposed bacterial infection. So we are using Neulasta in people who present with low neutrophil counts or low white blood cell counts to make sure they don't get anything else. But in and of itself, it probably doesn't do too much against COVID.
But for somebody who's on maintenance therapy and is perpetually immunosuppressed, do you think it's wise to get it preemptively? Neulasta, I mean.
It's a great question. I mean, the bigger question is if someone's on maintenance and otherwise in remission and is always neutropenic, the question is, should maintenance be held right now? And again, this is a question to ask your myeloma care team. For many people like this that need the maintenance, we know we can't stop it, we do give them Neulasta. But for people who have been in remission for years and are otherwise fine and always come in with their ANC at 900, this may be the time to hold off for a little bit.
All right. Thank you.
Okay, great question. Okay, caller 983-6757.
Hi, Jenny. Hi, Dr. Richter. It's Dana Holmes. How are you guys today? Thanks so much, Dr. Richter,
how are
for
you?
spending the time with us. It's just terrific. Really, it's just your knowledge is just so incredible. Thank you for that. I'm actually. Yeah, and I was super excited to read that paper yesterday about your colleagues at ICANN with the that serum antibody titer assay, because I honestly, just my observation, that this past influenza season may have actually masked a lot of this COVID-19, including in myeloma patients. So it would be really great for us to be able to tease out if any of us actually had it. So I'm looking forward to seeing that hit the ordering supply chain.
Yeah, absolutely. And this really, and as opposed to just telling us the virus is there or not, it lets us know who's immune. It also means that workers don't necessarily have to be fiddling with the virus itself. So it's more safety for the people who are in the techs on the front lines of this.
Absolutely.
And then again, if we know who's immune, because part of the thing that COVID really makes it difficult is right now, if you have an upper respiratory tract infection, we don't know, right? And so we don't want to start breaking out some of these big guns like tocilizumab or remdesivir that have potential downsides if we know you already have antibodies and this is another infection. So more ways that we can help avoid giving unnecessary risk to people, always a big plus.
Absolutely, and I can honestly see this helping somewhere down the road of, when IVIG is actually pooled IgG. So if perhaps some of these antibodies are going to find it into the IVIG supply someday for everybody too. So that's really terrific. There's another study that came out from France. It's a non-randomized trial that coupled azithromycin with hydrochloroquine.
Hydroxychloroquine, yes.
Thank you. And it was really impressive. I mean, again, I wasn't sure if it was mild or moderate cases or severe cases, but most of those people who had the combo changed the PCR from positive to negative in just 5 days. I mean, that's like taking Tamiflu, for crying out loud.
Yeah, I mean, so the issue is because you can have this prodrome of no symptoms to begin with, those people may have converted to PCR negativity, but that was their natural course. They may have done that anyway. However, hydroxychloroquine may definitely improve this, and azithromycin, that Z-Pak that we always get, has anti-inflammatory properties. So even though it's not fighting off a bacteria, there are anti-inflammatory properties of azithromycin, which may help in terms of symptoms as well. So I think your point is really a great one. We don't know. Did that hurry up to get people negative viremic, or were they negative viremic anyway, but it made them clinically better to get better? And either way, it's a win.
Right. Well, now, you were hearing the term immunocompromised, having a suppressed immune system. And if one has this, that there's obviously a higher risk for major complications from COVID. And cancer patients are obviously included in this, and so are myeloma patients. And so we get that. We know that the risk of complications is higher and likely contracting it is higher. But what does it actually mean to be immunocompromised? Which biomarker metrics tell us our current immunostatus? Which labs do we look at? I mean, I would imagine our labs can change daily. So do we rely upon this to know our immune status at any given time? Is it prudent to do that, or do we just err on the side of caution right now due to the very nature of having myeloma, or smoldering myeloma in my case, knowing our immune function likely stinks, and proceed just using the utmost caution?
You know, if you continue to ask such great and eloquent questions like this, we're going to bar you from asking any further questions.
I am. No, I'm done.
We have like 8 other questions. So.
No, this is a great. No, it's absolutely fantastic.
Awesome.
The short answer is your last statement is perfect. Everyone should exercise extreme caution. At the end of the day, the immune system is not one lab test. It's not even 2 lab tests. The majority of our immune cells and our immune function, we don't check on a regular basis. We don't check our NK cells. We don't check our dendritic cells, our Tregs. We don't check all of the individual components. The best we have is what are our immune globulins and what is our white blood count and lymphocyte count. One of the things that seems to have a negative impact on outcomes for COVID is lymphopenia, a low lymph, not neutropenia, but lymphopenia. And the question
I read
is,
that.
When people have lymphopenia and get sick with COVID, was it because the virus itself made them lymphopenic, or did they have lymphopenia from other reasons like myeloma or their drugs? And we don't know that answer. So I think looking out to maximize an individual's lymphocyte count, their neutrophil count, and their immunoglobulins right now is probably to an advantage. But someone I was talking to yesterday introduced me to a term that I've never heard before that I'm going to steal from her. She says, well, there's not just immune compromised and immune competent, there's immune challenged. And she considered herself immune challenged, not immune suppressed. So there's shades of gray in there. And because we don't know every factor at every time, I think right now is everything should err on the side of precaution.
Good. Thank you so much. Thank you so much for taking all my questions. Okay, take care.
Yeah, awesome questions, Dana. Okay, caller 876-3967. Go ahead with your question.
Hi, Dr. Richter. My question pertains to, I recently started a regimen of venetoclax, Velcade, and Dex, and specifically in order to minimize my visits to the office, I was wondering if I were to suggest to my myeloma specialist to pair Nilaro instead of the Velcade with the venetoclax. Would that be a safe pairing to suggest and have a discussion in order to less frequent the doctor's office?
I think it's an absolutely phenomenal question to have. The reality is we have very little data on that combination. So the Bellini trial, which is the big registration trial, we actually know very well the risks and benefits of Velcade with venetoclax. We know a little bit less about Nilaro and venetoclax. That being said, I think it's a great idea to have that conversation. There is a little bit of side effect overlap, but I think the dosing can be done in such a way to make that safe. Now, again, there's facets of your disease that he or she may know far better than I. but I think it's an extremely reasonable thing to reach out to them and say, listen, I want to minimize my visit. Is there any way we can switch it over to tomorrow and talk about it? So I think it's a great idea.
Great. I will do that. Thank you so much.
Of course,
yeah,
sir.
Great. Great question. Okay, caller 8690-8066. Go ahead with your question.
Yes, hello, Dr. Richter, and thank you, Jenny. My husband is on Revlimid, and my question is, are the components of this drug made in China, and will it affect his ability to continue getting the Revlimid?
Really great question. It's something a lot of people are asking. I can tell you that, first of all, the one thing about China is that in the last 24, 48 hours, there have been no new cases last time I looked at the data from China, from Hubei province in Wuhan, where this originated. So the fact that they're on the downslope is actually a good sign globally about the light at the end of the tunnel of all this. That aside, I can tell you that the people at BMS Celgene in particular who manufacture Revlimid have literally been, even though people are at home, they're literally on the phone nonstop, and we've been in contact with them, making sure that people have continued supply of drugs. So I would not be concerned about that at the moment. I think that there are a lot of ways that we're able to get over this. In a pinch, and I mean in a real pinch, there's alternate dosing strategies where Revlimid could even be taken every other day instead of every day. But I doubt we're going to have to come to that because the companies have been really good about ensuring that drugs going to be available.
Thank you so much, Dr. Richter.
Okay, great question. Okay, caller 296-7020. Go ahead with your question.
Yes, thank you, Dr. Richter, and thank you, Jenny, for doing this. This is a very good thing. This is Dennis Crow. I'm a veterinarian, actually, and my wife has multiple myeloma, and she has it fairly significantly. But we're waiting for a CAR T trial at this time. She has had her cells harvested, and so we're about 4 or 5 weeks now from probably getting those cells. Should you think we could, one, go ahead with that? That's the number one thing. Two, I've heard a lot and been reading a lot about just simple things like elderberry and how it may also be helpful in the immune system related. And then the third, hyperbaric oxygen has been used during the Spanish flu in 1918, and it was used successfully. This was hyperbaric air only with air pressure. And so I know those are successfully treated for patients that had the Spanish flu and were near death, cyanotic, unconscious, taking their last breaths. And when they got in the chamber, they were able to then survive, actually truly survive after several treatments. Can you comment on those three things then for me, please? Thank you.
Whole lot there. So CAR T is difficult. So this is something, obviously if she's in line for a CAR T and her cells collected, she's at one of the top myeloma centers. So I can assure you whatever the decision that they decide on, I have no doubt it's the correct one. A lot of this depends upon the status of their hospital. So if it's a hospital that is being overrun by COVID, that changes the dynamic. How well controlled is your wife's disease and what options they have. So let's say we have all the freedom in the world and this is an earlier phase relapse and the bridging therapy she's on is working perfectly. It may be the better part of valor to delay the infusion and keep her on the bridging therapy until such time as it becomes safer. If this is a more advanced scenario where there are no real good options and they can still give it, I don't think there's a contraindication to going ahead. However, if an alternative can be found, that may be optimal. As far as
she's not on any current. Oh, she's not on any current bridging therapy at all right now. The doctor thought that we would be able to move right along from where she was to, to getting into the CAR T. So, getting her cells. So she's not in any bridging therapy at this time at all.
Which is actually
several weeks out.
No, but that's a good. That means that they're confident that even without therapy on that time, things will hold steady. So again, unfortunately, this is a study-by-study question. And if you're getting a CAR T without, you don't have to tell me where she's going. I'm sure the doctors there have a clear plan for this.
Thank you very much.
For elderberry and hyperbaric oxygen, I've seen those floating around. We just don't know. Elderberry probably has some immune modulating effects. Unclear how much it helps. This may be along the same lines as turmeric curcumin that a lot of people with myeloma take, where it may have some positive effect, but we don't know fully how much, so that's going to be a tough one. And hyperbaric oxygen is less available now because we just fewer indications for it. And unclear if the same mechanism by which it held off the flu will help. The one thing I would say as a veterinarian, I would ask you, one of the things I've seen floating around is a discussion that there are a number of ventilators that are available for large animals like pigs and elephants and giraffes that may be repurposed to use for people. I don't know if you can comment on that.
Oh, sure, I could. I'm with basically an association called the American College of Veterinary Critical Care, Emergency and Critical Care. In that college, we're all basically diplomates in that college. We have donated, if you will, lent, if you will, our ventilators to many, many different institutions all across the country. So these are, just good ventilators that are just having all the different ways of ventilating, mostly small animal patients. That'd be cats and dogs that are critically ill. And that actually gets me into a question. We're still opening in our centers. And so we're not, ventilating our patients, because those patients those ventilators went to the human hospitals. You guys need them way more than we do. But what about the transfer of COVID-19 on pets' hair? It's to me, it's like almost like an adage of like a cardboard box. If it's able to cough, people are able to cough and get the viral particles on the pet's hair. Don't you think that our veterinarians that are critically caring for these patients should also be almost protected like you would an ICU doc as well?
Completely
with
agree.
the N95 mask?
Well, N95s are really only indicated this time for aerosolizing procedures. So if you're doing any procedure on an animal that's aerosolizing or potentially aerosolizing things, then an N95 mask with goggles is absolutely needed. For routine care, face shield, surgical mask, and gloves with gowns should absolutely suffice.
All right. Okay. Well, it's good to have a chance to talk with you. Thank you so much.
Pleasure, sir.
Okay.
Thanks so much for your great questions. We have a hard stop on the software at 1:30, so we'll just keep going if you don't mind with a few caller questions. Caller at 241-9438.
Two more, just because if we can just do two
Yeah,
more.
hi, I'm here.
I had a call at 3. Oops.
Sure. Oh, yeah, sorry. Okay, go ahead with your question. 2 more questions then.
Hi. Thank you, Jenny and Dr. Richter. I am possibly coming close to a relapse. The numbers were rising, and I had a spot on my zygomatic arch. And so my doctor went back to my old frequency on Pomalyst, and I can't think of the name. I was so surprised you did that. On Kyprolis.
Oh, Kyprolis.
Kyprolis. And we're going to go that route until further notice. But I went and saw the radiation oncologist, and they're recommending me having radiation to that area. On my left side, it's the corner of my eye and that arch area there. Now, that's supposed to start next month. And then, of course, I'll stop infusion. But what is this radiation going to do to my system? And with the virus, will it inhibit it, cause me to be more susceptible to it? And
no, in general, not. Oh, sorry.
Generally, I know, but I have to go in every day for 2 weeks. But it's in a separate building. And this is way off, talking about protein inhibitors. Someone has talked about them doing some studies on it and the COVID virus. And I know there's tons of, like you said, medications out there. We don't know yet, but I'm just throwing that out there. Anything about protein inhibitors and the COVID virus?
Do you mean proteasome inhibitors?
Yes.
Oh, like carfilzomib? We just don't know enough yet about that. In terms of the radiation,
in a weird way, is it going to protect me?
Unclear. Again, there are immune modulating drugs. Drugs like Pomalyst and Kyprolis, it's not that they kill every immune cell, they activate others, so there may be some protective nature. It's really case by case, and unfortunately we just don't have enough information yet to say one way or the other. The radiation itself to the zygomatic arch, depending upon the size, is usually minimally toxic because it's not a very large area. The other, you're concerned about going back and forth twice a day. Once a day is a real concern. So if you just started on KPD and the radiation is planned for a little bit of time, but your symptoms are getting better because it's shrinking, you may be able to hold off. On the other hand, radiation in Kyprolis is generally a safe thing. It's the radiation in pomalidomide that's actually more of a concern because the two together can give you more lowered blood counts. So, again.
Well, it would be discontinued. There's no doubt about that. They've already told me that.
Yeah. The other question that you may ask your radiation oncologist is there a way to do this in a fewer number of fractions? So depending upon the area of radiation and the need, sometimes you need 10 fractions, so 10 visits. Sometimes you can do it in 5. Sometimes you can even do it in 1. So I would reach out to your radiation oncologist to say, understanding that you plan this, I don't know if they told you, 5 or 10 sessions?
I think it's 10. I'm not too sure because she said like 2 weeks, so I'm assuming 10 because I had it in my head before. And it's going to be half as much as what I had before. I think she said 24 U's. That makes sense?
It's usually gray. It's usually, so if they do 10 sessions, they often do 300 centigrade times 10 to get 30, or she may be giving 240 a day times 10 to give you a total of 24. But depending upon the type of radiation oncology, sometimes they can do a higher dose in fewer fractions depending upon where the area is. So you should ask if they can do it in fewer fractions.
Yeah, well, they have to be careful about my eye, and, they told me about that. But that spot was there a year ago for my PET scan, and my numbers were going up just a little bit. I mean, I'm still in the safe zone, but we are seeing changes. So all they did was just increase the frequency a little bit back to what it used to be. And they were trying to step back because of my white cell count. So right now it's holding okay.
Excellent. I wish you the best.
Great.
Well, thank you very much.
And thank you. Question. Oh, sorry. Okay, I'm sorry. We have one last question, 935-6515, and then we need to call.
Hello?
Go ahead with your question.
Hello?
Hi.
Yep, we can hear you.
Oh, I'm sorry. I had a stem cell transplant at University of Maryland, and after that, about 3 months after that, I had PCP pneumonia. I had bronchitis on and off. So the doctor said to me, I think it'd be a good idea to get the IVIG. So I've been doing that for the past 5 months, and it has brought up my IVIG numbers. My IgA and my IgM are just very low. But it did boost that one, and I haven't had bronchitis. I've been doing really well. My question is, do I discontinue going for the IVIG because of the jeopardy it would put me in with possibly going to the hospital to get the infusion? The infusion's about 5 hours. So do I I don't know which way to go.
So if you're at the University of Maryland, you're probably either seeing Ashrafadros or Memicocoglu?
No, actually, Dr. Rappaport, and he has sent me to GBMC, Greater Baltimore Medical Center, and my doctor there is Dr. Ellman.
Oh, so great group there.
Yeah.
No, they're a phenomenal group. What I can tell you is that these are, unfortunately the answer, it's a personal decision. I can tell you that if you've been not having infections and your IgG is essentially normal, risk-benefit, I think that it's not unreasonable to hold it. But understanding that you had PCP pneumonia, which is still something we don't see that often, you may be someone who needs it more than others. So really, I think your question is a great one, and this is something that really should be directed to the team in Maryland, and they'll be able to have a discussion specifically for you. What are the risk benefits?
Right. If all of the progress I have made with the IVIG, if I were to miss one or two of the infusions, do I lose all the progress I've made?
No, in general you don't. But I would emphasize not just making the decision on your own, because
Okay.
there are other little things that may be relatively insignificant to you, but the team at Maryland will expertly say, well, because of this level or because of that clinical feature, you should really continue. Or they may say, your IgG is normal, you can hold it. So you're working with a great team. I know they will guide you the right way.
Okay, thank you both so very much.
Great.
I really appreciate it.
Oh, thank you so much. Thanks for your question. Thanks, everybody, for all your amazing questions. And Dr. Richter, thank you so much. This has been just an outstanding show, unbelievable show with so much information. So we will post the show later. It speaks to the need to see a myeloma specialist if you haven't captured that point by now. I just want to comment on a few other things that we have in terms of support. So in terms of staying fit, like what you were saying, Dr. Richter, earlier about staying fit and keeping moving, and we have a Muscles for Myeloma program that we're running, and it's all virtual, and you can join that. And you can log your minutes and chat with other people who are doing the same thing and coming up with creative ways to exercise at home. We have a Myeloma Coach program that you can reach out to and find on Myeloma Coach to answer some of the simple questions, to maybe offload some of those questions from your doctor. And then we have the Health Tree platform, and since everyone's at home, they can fill out their Health Tree profile, because we will probably be running a COVID-19 study inside of Health Tree, so you can get all your information in there now. But Dr. Richter, thank you so much for your time.
My pleasure. Thank you so much.
Unbelievable.
For everything you do. We really appreciate it.
Really, really unbelievable, your expertise and your willingness to share it. So thank you so much, everyone, for listening to Myeloma Crowd Radio, and we invite you to tune in next time to learn more about the latest in myeloma research and what it means for you.